Welcome, everyone. We're so glad you could join us this morning. My name is Ari Wassner. I'm the medical director of the Thyroid Center at Boston Children's Hospital.
And my name is Biren. I'm the surgical director of the Thyroid Center at Boston Children's Hospital. And our team here provides care for children, teenagers with a variety of thyroid conditions, including thyroid cancer. And in our last live event a few months ago, we discussed thyroid nodules, so sort of lumps on the thyroid, and why they require a multidisciplinary team to take care of them. And today we're going to focus that down and really try to talk about what happens if that thyroid nodule comes back as being thyroid cancer, in terms of what the next steps would be in management, and also what you should look for as patients and patient families when choosing a team to take care of a child with thyroid cancer. To start off, Ari, do you want to just sort of give some basics about thyroid cancer and what it is?
Sure. So, thyroid cancer is a relatively rare form of cancer in children, and it comes in a couple of different forms. The most common form is called papillary cancer or papillary carcinoma, and that's most of what we're going to say today is related to that because it's the most common form. There are other forms like follicular carcinoma or medullary carcinoma, which are a little bit different. So most of what we're going to say today relates to papillary and follicular thyroid cancer. Um, so thyroid cancer is actually quite common in adults. And so in adult practice, adult endocrinology, adult surgery, taking care of thyroid cancer is a pretty common thing, but it's pretty rare in kids. And so it can be difficult for pediatric practitioners to have a lot of experience treating kids with thyroid cancer unless it's something that they really focus on. Just in terms of kind of clinical context, sort of how these things come up, usually, Biren, as you alluded to, thyroid cancer usually shows up as a mass or a lump in the neck, a thyroid nodule, and that goes through a whole evaluation process to determine whether it might be a cancer. And that's something we talked about in our last webinar, and I'll invite people to check it out if they are interested. But if that turns out to be a thyroid cancer, the sort of overall treatment scheme that we use consists of three sort of main components. The first and most important component for treatment of thyroid cancer is surgery. So basically just physically removing as much of the thyroid cancer as we can safely. That is the best treatment. So doing that in a thorough and careful way upfront is important. After surgery, in certain cases, there are a few other types of treatments that we sometimes use, one of which is called radioactive iodine to kind of clean up any leftover thyroid cancer. We'll talk about that in a bit. And also thyroid hormone treatment, which can be used in certain cases. So that's kind of the overview. Kind of surgery, radioiodine, and thyroid hormone replacement are the sort of mainstays of treatment for most pediatric thyroid cancer. The other thing I always try to sort of orient people to when they get this diagnosis, I think it's very natural and understandable when parents and patients receive a diagnosis of thyroid cancer. Cancer is a very scary concept, and people, I think, naturally want to sort of move ahead and get it taken out as soon as possible. I think it's really important to realize that thyroid cancer in general grows quite slowly. And that means that patients and families have time to do some research and look into finding an experienced team to take care of their child. Kids with thyroid cancer in general do extremely well. It's extremely unusual for kids to die of thyroid cancer. Survival rates are well over 95% long-term, meaning 30 or 40 years. So our job is to evaluate each patient individually and give them careful and thorough treatment while minimizing the complications of that treatment. And because they grow slowly, it's important to take that time and take a careful and sort of thoughtful approach to treatment from the outset to help set you up for successful treatment and avoid unnecessary problems later on. So that's kind of the overview of treatment and sort of how I think about it. As I said, surgery is kind of the most important first step in that process. So Biren, I'm going to sort of ask you to maybe lay out for people sort of how you approach thyroid cancer surgery in kids, sort of thinking about how much surgery to do, what that's like for kids as they go through that process, and how you counsel families about the experience and risks of surgery.
Sure, yeah. So, as you mentioned, surgery is the primary treatment for thyroid cancers in terms of trying to reduce the overall amount of thyroid cancer cells in the body, right? So we want to completely take out as much of it as possible. And that generally involves taking out the entire thyroid gland or any residual thyroid gland that's left over, and any associated lymph nodes that may be involved. One important thing about children as compared to adults is they more often present when they have the first diagnosis of thyroid cancer with lymph node involvement. And we detect that either by exam during a clinic visit or on ultrasound, which we often use as a sort of the main diagnostic test, the main imaging test, or other imaging techniques if they've come in with those already done, like CT scans or others. And as high as 70% of children with thyroid cancer, when they first come in, will already have lymph node involvement. And what the operation entails really is, it's done under general anesthesia, so the child is completely asleep for the operation. They don't remember it. They don't feel anything during the operation, and really just almost universally a one-night stay in the hospital, mostly for monitoring purposes. There's not a lot of pain associated with the incision, which is a small sort of transverse incision, we call it, in the lower neck. And they're generally able to eat and drink as soon as they wake up. And in fact, we want them to, because we want them to support their calcium levels. I'll talk a little bit about that in a second. And then generally go home the next day after a couple of blood tests for calcium levels and making sure that they're able to recover well. Thyroid surgery is very safe in general. It does have a few complications that I always talk about with patients and their families to cover before we do the operation. And it's probably worth mentioning those here. There are three main things that we talk about with thyroid surgery in terms of complications. The first is bleeding, not because it's going to be a large amount of bleeding, but because the neck is a small space that controls, that has your airway in it. And even just a few tablespoons of blood in the neck can cause compression of the airway. And so that's the main reason in my mind that we monitor patients after surgery for a night. That is a very rare occurrence that sometimes requires some intervention or a trip back to the operating room even to control. More importantly are the complications that have an impact in the postoperative period. And that is, one is that there's a nerve on either side of the airway that's behind the thyroid that controls the vocal cords, and that's called the recurrent laryngeal nerve. We talk about that with patients every time we talk about thyroid surgery, and most of the time that nerve is most of the time that nerve is totally fine. And if we were to injure it, it would cause hoarseness of the voice and potentially difficulty with swallowing, because the vocal cords also control the closure of the airway to prevent what we call aspiration, so that when you drink your orange juice, it goes to your stomach and not into your lungs. Again, a very rare complication, and one I'll talk about later in terms of how we monitor for that and how we make sure that we keep our complication rates low. The other third complication potential is something called the parathyroid glands that sit behind the thyroid. They're important in controlling calcium levels in the blood. And if they were to become dysfunctional after surgery, either by being inadvertently removed or by being stunned from the operation, the calcium levels in the body can fall. And so what we do for that is we automatically give patients that have their whole thyroid taken out calcium and vitamin D after surgery, and then we slowly wean that off over the next couple of weeks after the operation. Now, I say all of that in terms of those three potential complications, but want to frame it very importantly in the understanding that those complications are extremely rare. We've looked at our own data, we know what the expectations are, and we know that the risk of permanently injuring one of those structures or of having a bleeding complication after surgery is well in the 1% to 2% range. So well below sort of a 3% threshold that we use as something we want to maintain for making sure we're doing safe thyroid surgery. All of that is to say, it's really important that your thyroid surgeon be a well-experienced thyroid surgeon. And the way we define that is really based on the amount of thyroid surgery that they do. For that reason, in our center, we focus our thyroid surgery experience in just two surgeons, myself and one of my partners, so that we concentrate that experience in just those of us that are doing that surgery. We don't want all of our 25 partners to be doing one or two surgeries on the thyroid a year. In fact, we concentrate all that effort. And with that concentrated experience comes a clear decrease in the risk of complications. So that's the broad overview of surgery. Maybe I'll kick it back to you, Ari, and talk about to talk about the the steps after surgery in terms of radioactive iodine and other medical care.
Yeah, sure. So, as Biren, as you're describing, right? So, kids go for thyroid cancer surgery. They typically have their whole thyroid removed. Um, and then, as I mentioned, there sometimes, in certain cases, we will use another therapy after surgery called radioactive iodine. And the sort of idea behind that is that it's a radioactive form of iodine, which is just a mineral that you get in your diet, but it specifically targets thyroid cells. And we use it to destroy any thyroid cells that may be left over after the surgery. And they may be left over either because they were in a place that they weren't really accessible to the surgeon, either it was too difficult to take out, or it was perhaps in a distant place like the lungs that are not accessible, or maybe microscopic and we can't actually see it to remove it. And this is a very effective treatment particularly for kids who have what we think of as high-risk thyroid cancer. So these are cancers that are more aggressive, that maybe have spread to either lymph nodes, as you heard can happen frequently, or even to more distant areas like the lungs. When we give radioactive iodine to those type of patients, we know that it can reduce the risk of thyroid cancer coming back in the future. And so it's a very useful treatment in that way. And I think it's also important to emphasize, as Biren said, many kids, when they present with thyroid cancer, when they first get diagnosed, they already have lymph node involvement and maybe involvement in other areas. I think that can be scary to parents because they say, well, it's already spread. And I think it's important to know that even when we have spread like that at diagnosis, thyroid cancer is still very treatable. And so that doesn't necessarily mean that, all is lost. We have effective treatments in those situations. However, radioactive iodine is not used for all children with thyroid cancer. And this has been a change over the last number of years, that there used to be a little bit more of a reflexive sort of, you have thyroid cancer, you get radioactive iodine. And I think we now appreciate much better that kids who are at lower risk, who have less aggressive thyroid cancers that really haven't spread, radioactive iodine doesn't really do much for them. They're already at low risk. And so we need to be much more careful about the potential side effects of treatment, which every treatment has side effects. And so it's really important when thinking about the choice of giving radioactive iodine to work with a team that's experienced and can help sort of weigh the risks and benefits in a particular child's case. Is this going to be a useful therapy? Is it worth doing? And is the benefit going to outweigh the risk? And so I think working with somebody who has experience and expertise in that area is really important. I also mentioned briefly thyroid hormone therapy. So that's sort of, radioactive iodine is one adjunctive therapy. Thyroid hormone therapy is another. So most patients, as we said, have their whole thyroid taken out. And so for that reason, they all need to receive thyroid hormone replacement for the rest of their life because they don't have a normal thyroid gland. It turns out that in some cases, we will give a little bit extra thyroid hormone, a little bit more than what you need just for replacement, and that will help actually suppress the growth of any thyroid cancer cells that may remain. And that's something, again, that we would do for patients who have more advanced thyroid cancers, where we're a little bit more concerned about the possibility of it coming back in the future. Not every patient needs that, and again, that's a discussion that you would have with your thyroid cancer care team to decide if that's something that's necessary. But everybody receives some amount of thyroid hormone if they've had their thyroid removed. And then lastly, I'll just say briefly, those three, surgery, radioactive iodine, and thyroid hormone, are things that pretty much everyone, I shouldn't say everyone, but we at least consider. Those are kind of standard therapies. There are rare cases of children who have really aggressive thyroid cancers that don't respond to the standard treatments that we use. And they may have progression of disease even with those treatments. For those patients, there are newer kind of specialized medications that have been developed over the last number of years to specifically target those progressive or refractory cancers. And those kind of treatments are available in specialized centers that are experienced in their use, such as ours and others. And these can be very effective treatments for a type of these rare progressive cancers that didn't used to have great treatments. So that's a kind of an exciting development that's come about.
And Ari, you mentioned that patients will need to be on the thyroid hormone for a long time, and that we need to keep an eye out for keep the thyroid cancer from coming back. So, what do we use, and what is the sort of standard in terms of follow-up for these patients? As you mentioned, it's a very long follow-up, and we want to keep an eye out for any evidence of cancer recurrence. So, what do we typically do around that?
Yeah, so that's a really important point, the sort of idea of long-term surveillance. So just to sort of frame that issue, I'll sort of come back to something I said earlier, which is overall, kids with thyroid cancer do extremely well. So uh, the long-term outcomes are excellent. Survival is well over 95% for many decades, 30, 40, 50 years. Um, the one thing that we do need to look out for, though, is that thyroid cancer can come back. It can recur uh, even years or decades later. So we do have to keep an eye out and be monitoring people carefully to make sure that if there is a recurrence sometime down the road, that we detect it early and we can take care of it before it causes any problems. So because of that, we're always doing monitoring of patients who've had thyroid cancer. And typically what that consists of is a combination of imaging surveillance and some blood tests. So the imaging that we typically use most commonly is ultrasound. It's non-invasive, it's easy to do. And we'll use that to look in the neck to see if there's any sign of thyroid cancer growing back. And we'll do those periodically. Often we'll do it about 6 months after surgery and then about a year later. And then depending on how things look, if everything looks good, maybe annually after that for a while, and then potentially spacing out if everything looks stable. At the same time, we're doing periodic blood tests. So those are looking both at the level of thyroid hormones, right? Because we're having to give kids thyroid hormones to replace what they need, maybe a little extra, as I mentioned. And we're also monitoring a protein in the blood called thyroglobulin, which is a marker of thyroid cancer, thyroid cell growth. And if we see that starting to rise, it's essentially a tumor marker that says maybe there's some thyroid cancer growing back that we need to start looking for and identifying. So, and those kinds of surveillance will go on, as I said, certainly for many years. They may become less frequent over time if everything looks stable, but the goal is really to watch out for recurrence or to monitor in those the minority who have persistent disease over time. I think the other thing that's really important to consider is looking out for the psychosocial well-being of these kids and their families. You know, although kids do extremely well from the medical side, getting a cancer diagnosis is a big deal. It's a real burden for these kids and their families to carry, and I think they really need good support. And so I think having a strong team that includes social work, mental health providers who can help them kind of work through that process is really important to their overall well-being. And that's a piece of the Thyroid Center that I'm really proud of, and I think is a key part of long-term thyroid cancer care.
Yeah, you know, it's really, I'm really glad you brought that up, Ari, because I think it really speaks to one of the main questions I'm hoping to answer for parents and patients with this webinar is sort of what to look for in a team or in a center when it comes to seeking out people to take care of your child with thyroid cancer. And you know, the fact that we have a social worker and psychologist in our center is so crucial to that. In addition to, you know, maybe what we think of as the more standard multidisciplinary team, which includes, you know, you and I as the medical and surgical care, but also, you know, radiologists that are very dedicated and specific to thyroid ultrasound and thyroid imaging. We have a pathology team that's top notch that really focuses on thyroid pathology. In fact, some of the people we work with are the innovators in that field. And have helped to define the way we look at thyroid specimens. So, you know, having that group of people and you know, just to mention that this group of people comes together once a month and does a thyroid tumor board, right? And we review patients with thyroid cancer on a regular basis to make sure we're providing top-notch care for them. And I think that's something that is critical to the way we function, but also is critical, I think, no matter where you go to get care, you want to make sure you have an integrated team like that that's able to care for the child from that multidisciplinary, with that multidisciplinary management paradigm, if you will. I think the two big takeaways are that type of care couched in a surgical team that's extremely experienced with high volume, and that high volume leading to experience to minimize complications from thyroid surgery and to maximize the potential for the thyroid surgery to be curative, and also an experienced medical team that's able to provide the radioactive iodine care afterwards, as well as the long-term follow-up and surveillance that you mentioned.
Absolutely. So I think just looking at the time, I think why don't we take a look and see if there are some questions that came in from folks in the audience. So here's one that we got ahead of time. It's several times. I think this is one I'm going to put to you, Biren. So this sort of question that you brought up and tried to emphasize about the volume of thyroid surgery. So, how would you sort of counsel people as they're looking around to figure out where's the best place for surgery? Like, how should people assess, what kind of surgical program and the experience of their surgeon to help have the best procedure?
Absolutely. I touched on earlier, and I think you mentioned too, Ari, that thyroid, well, first of all, thyroid disease in children is rare. Thyroid cancer in children is very rare. And so therefore thyroid surgery in children is rare. But to get back to it, one of the most important things about thyroid surgery and good thyroid surgery outcomes is the volume and experience of the thyroid surgeon. And so when seeking care for that, you want to make sure that the surgeon themselves is someone who has experience and high volume in doing thyroid surgery. There is some guidance from several societies about what that means. And in general, that means at least 15, if not 30 thyroid operations a year. Now that's a relatively small amount compared to adult surgeons who see quite a bit of thyroid surgery, but I'll emphasize that children are not just little adults. And so you really want your child to be cared for at a place that is geared towards taking care of children. And so the ideal location for taking care of your child with thyroid cancer is a children's oriented facility that also has a high volume pediatric surgeon that does thyroid surgery. And those two things together are relatively rare, but we do exist out here, and those are very important, I think, attributes of the center that you want to seek out care in. One other question that's come in, Ari, is I think something that's come up quite a bit is if you have a family member that has thyroid cancer, then what kind of precautions or what kind of testing needs to be done, if any, for for siblings or for children of people that have thyroid cancer?
Yeah, I think that's, as you said, that's a question that comes up quite a bit, especially in thyroid nodule clinic, or as we see these kids with thyroid cancer. So I'll try to sort of frame that with a couple of things. So first of all, most thyroid cancer, at least the thyroid cancers we're talking about today, papillary and follicular thyroid cancers, do not tend to be hereditary. So they don't tend to be inherited conditions. They're mostly sporadic, meaning they just kind of happen and we don't really know why. So that's one thing. The other thing is that thyroid cancers are pretty common, as we've said, in adults. And so the combination of those two things means that it's actually not that unusual for a child to have some adult relative who has a thyroid cancer, whether it's a parent or an aunt or uncle or grandparent. And so the fact that just having one relative with a thyroid cancer of this type probably is not a significantly increased risk of thyroid cancer in the child. And so we don't generally recommend specific screening like ultrasounds or things like that if it's just one family member. Having said that, there are rare cases where there can be familial types of thyroid cancer. One of the big ones I think is the other type that I mentioned, medullary thyroid cancer, which is really in some ways a completely different disease, but many of those are hereditary. So if there's somebody in the family with medullary thyroid cancer, that person should have genetic testing, and that might influence what we do for the kids. If it's not medullary, there are also some very rare families that have certain either known genetic syndromes or papillary cancers that run in families without any specific gene that we can identify. So if there's a pretty strong family history, multiple family members who have thyroid cancers, that's a different story. And those are the kind of situations where it's helpful to talk to an expert and sort of think about that specific situation and case, and does that rise to a level where we should be thinking about screening or doing some other kind of looking out for the kids. But in general, I'd like to reassure people, if you have sort of one family member with thyroid cancer, that's not necessarily going to put kids at significant increased risk.
Yeah.
All right. This next question, it looks like, is more kind of comes back to the surgery piece, which is kind of about extent of surgery. So the question is basically sort of as the surgeon, how do you decide whether you actually need to remove the whole thyroid? Do you really need to remove the whole thyroid, or could you just do half, or kind of how do you make that decision in practice?
Yeah, and I guess to answer that, I might back up and sort of comment about how we get to the diagnosis of cancer, because I think we covered it a little bit in the last webinar, but it might be useful to recap it here. When somebody comes in with a lump in their thyroid, a nodule, there are several ways to figure out what it is. The most commonly used is something called a fine needle aspiration, which actually is something that Dr. Wassner and his colleagues do in ultrasound clinic. And what they do is they use a very small needle to enter into the nodule and take out just a few cells with some fluid. And then we look at that under the microscope. And that is able to most times give us an answer as to whether there's cancer or not. There are situations, though, where that diagnostic test is not adequate, and we have a question as to whether the lump is cancer or not. And in that case, we do what's called a diagnostic operation. So I tell patients that their thyroid's like a butterfly sitting on their airway. And so if the lump is in one wing of the butterfly, we can take out just that wing, just that half of the thyroid, something called thyroid lobectomy. And that can then allow us to get more tissue to look at under the microscope and figure out exactly if it's cancer or not. While management after that is individualized, the general rule is if it is cancer, we will typically take out the rest of the thyroid gland. And so that means then going back for a second operation and removing the rest of the thyroid gland. And in children that are otherwise healthy, that's almost always a very safe way to do it. Um, However, if we've already gotten the diagnosis of cancer before I do an operation, so just from that little needle going in that tells us that it is cancer, then at that first operation, we typically remove the entire gland, the entire thyroid, that whole butterfly. And what that does is allows us to absolutely minimize the risk of any residual thyroid cancer. And as I mentioned earlier, we would also take out lymph nodes if they're involved as well. And that allows us to both minimize the risk of any residual cancer, but also makes administration of radioactive iodine somewhat easier. Often you can use a smaller dose. And thirdly, it also allows us to monitor for any evidence of persistent or recurrent disease with that protein you mentioned, thyroglobulin. And so there's a lot of reasons why removing the whole thyroid gland makes sense in the majority of cases with thyroid cancer. Ari, one question came in just now, and I think that's something you can definitely answer. We've done a study on this. How often are thyroid nodules cancerous? And I would say in children, obviously, is what we want to.
Right. Yeah, so that's an important question, and this has been studied now in a number of pediatric studies. So the answer is roughly 1 in 4 thyroid nodules in children turn out to be a thyroid cancer. That really applies to thyroid nodules that come to attention clinically. So like usually identified as a lump in the neck or something else. So it's about 1 in 4 roughly, and that's higher than in adults. So thyroid nodules are very common in adults, but they're less likely to be cancer, somewhere in the neighborhood of 5 to 10% in adults. Kids, thyroid nodules are rarer, more likely to be cancer, on the order of 1 in 4. However, I always reassure families that 1 in 4 is still the minority. So most thyroid nodules in kids are not cancer. And so I think it's, if you have a child with a thyroid nodule, I think it's okay to sort of take a deep breath, and we have to do some evaluation, but it's not like the old days where people used to, even physicians would say like, oh, it's a nodule in a child, you got to take it out.
Right.
It's not the case. It just needs a careful evaluation.
Yeah. And we're coming up on time, but I might just answer this one last question, which is, can there be thyroid cancer even if imaging studies, CT scan or ultrasound, only show heterogeneous properties? And that means that the thyroid just looks not uniform on the pictures, but sort of has black and white spots. There are no nodules visible, but there's fullness and difficulty swallowing. And just to answer that quickly, I think, yes, there are some instances where there are not nodules, but there is cancer within the thyroid itself, something called diffuse sclerosing variant of papillary cancer. That's pretty rare. And in general, it has certain features on ultrasound that are detectable. However, I will say that any child that has symptoms from their thyroid gland, especially if their thyroid gland seems big, symptoms like pressure or difficulty swallowing, they should be evaluated by a thyroid center to make sure that they don't need their thyroid removed for that reason alone, and also to make sure there's not a medical therapy that can decrease the size of their thyroid gland and make it less symptomatic. So it definitely is a symptom that is worth having patients evaluated. Ari, I'll turn it over to you to maybe just give some last conclusions, and I think we're probably running out of time. So
It looks like it says. I think we
so
just
one
got a
more.
note. It says we have time for one more question.
Oh,
If you're
great.
good
Okay.
with it.
Yep.
This one, I think this is one that we get a lot actually. Does autoimmunity, Hashimoto's or Graves, predispose one to thyroid cancer? So this is actually a timely question, and a subject of actually quite a lot of debate, I would say, and some ongoing studies, including studies that we're looking at. But the real question is, autoimmune thyroid disease, which includes, as the questioner said, Hashimoto's disease and Graves' disease, is actually fairly common, more so in adults than in kids, but still in kids. And the question is, if you have this sort of chronic inflammation in your thyroid, does that increase the risk of developing thyroid cancer? And the answer to that is, it's not really clear. So there does seem to be an association. If you look in studies, do people have, if you look at people who have thyroid cancer and people who don't have thyroid cancer, there's an association between having autoimmune thyroid disease and thyroid cancer. What's not clear is whether the autoimmune disease is actually causing the thyroid cancer, or perhaps the thyroid cancer is actually causing an immune response in the thyroid, or whether it's just more likely to detect cancers in people who have autoimmune thyroid disease because those people tend to have funny or abnormal feeling thyroids, and they're more likely to get imaging. And so you might be more likely to find a thyroid cancer in one of those patients than you would be in somebody who's otherwise healthy, and you're just not looking at their thyroid. Because as we know, many of these thyroid cancers are relatively slow growing. So there is an association between those two things, it appears, but it's really not totally clear, at least to me, I think, that having one of those conditions makes it more likely to develop thyroid cancer. At present, there is no sort of recommendation that if you have one of these autoimmune thyroid diseases, that you should have sort of screening ultrasound to detect cancer. But it is something that I think is worth being aware of. And we do talk about with patients. So it's a complicated answer, and I think still remains to be fully sorted out.
Yeah, and one, as you know, that we are actively interested in trying to figure out with our own experience. One last question, Ari. Can colloid nodules become thyroid cancer?
Yes, another good question. So I will tell you that I would say that the official answer is no one really knows for sure so colloid nodules are essentially a kind of benign nodule. So they're nodules that are just kind of essentially normal thyroid cells, but growing in a slightly abnormal way, but they're not cancer, at least at that stage. Whether nodules that are, benign can become cancer over time, or whether a cancer is born a cancer, and if the nodule is cancer, it will always be cancer, and it will be small and then get bigger. Nobody really knows the answer to that question. But I would say, based on the literature that's out there, and I would say this comes mostly from adults, not from kids, I think it's pretty unlikely that colloid nodules will convert into a thyroid cancer. But it's not impossible, and I don't think we know for sure. I think the key is, if there's a benign nodule and it's of a significant size, we will usually monitor those by ultrasound over time. And if they're not growing and they're not changing, we know from studies in adults that they're very unlikely to be a thyroid cancer. Biopsies are not perfect, so sometimes we get benign results that turn out to be cancer later, and that's why we monitor. But I would say, in general, if it's truly a colloid nodule, it's benign, if it even needs a biopsy, and it's stable on monitoring, very unlikely that that's going to turn into a thyroid cancer down the road.
Yeah. Great. Thank you, Ari. Well, we're running up on time, so I think we'll just conclude by saying thank you for joining us. If you're interested in continuing to ask questions, there's the opportunity to do that on the Facebook page. And in the chat, we're also putting our contact information so that you can contact us if you have any additional questions. There's a phone number and an email address there. And if you're interested in learning more about the Thyroid Center at Boston Children's, you can go to bostonchildrens.org/thyroid, and there's more information there, including archived webinars from prior stuff that we've done here. So thank you. Please enjoy the rest of your day, and thanks for joining us.
Thanks so much.